Welcome to ASRM Today, a podcast that takes a deeper dive into the current topics in reproductive medicine.
Hello to everyone. I'm Dr. Jeffrey Hayes, your host for this episode of ASRM Today. Today I'm speaking with Dr. Joop Laven. Dr. Laven has been on the front lines of the COVID-19 pandemic in Europe. Dr. Laven continues to work in the reproductive medicine space with other professionals who are looking for solutions in these perplexing times. Dr. Laven, thank you so much for joining us today.
You're welcome.
So please tell our listeners a little bit about yourself. What is your specialty and where do you practice?
I'm a reproductive endocrinologist and infertility specialist. I was trained in OBGYN in the 90s, I think, mid-90s. And then I moved from Nijmegen, which is a place in the eastern part of the Netherlands where I did my training, to Rotterdam, which is one of the biggest harbors in the world, which is located near the coast, at the North Sea side of the country in the west. I did my fellowship REI there. I'm based there since 1998, I think.
Where are you at the moment with patient care? Are you providing all care, selected care only, planning to resume care?
We are at the moment resuming our care, and we are planning to provide all the care which we did in the past within the next few, let's say, weeks. There's one peculiar thing which you should know is that although everything was, let's say, stopped due to the lockdown in the Netherlands here, we were already planning to stop our activities for about 3 or 4 weeks because we were refurbishing my lab, which is extended to, let's say, twice the size as it was. So that was a kind of a lucky thing which came along with all the bad events COVID-19 brought us. So to say it's the impact COVID had on my clinic was limited because we already had a kind of calculated thing that we had to close down for 4 weeks, which actually became about something like 8 weeks. But we are initiating all treatments again, and I think within about 4 weeks we will be fully up and running again, doing some, let's say, 40, 50 cycles a week, which was the average which we did before COVID.
What has your approach been to dealing with COVID-19 as a disease?
Well, yeah, we were already closed down when COVID started, of course, because this lab extending thing. And in the Netherlands, the Royal College of Obstetrics and Gynecology advised us the same thing as ASRM and ASRM did, to be very prudent whether we should go on with treatment or not. And actually in the Netherlands, every clinic decided to stop treatment, not immediately, but mostly nearly immediately. So that happened about 6 weeks ago. And yeah, we are looking now at all kind of different info material, looking at whether it is present in semen, whether it's present in, or whether it might be present in oocyte, and what the risk it might be, which brings that along. So basically, if you look at the evidence which is now around, there is not very, let's say, hard evidence that there might be a kind of vertical transmission from the mother to the child. There's also not very convincing evidence that it is apparent in sperm. There are a few cases, but the majority of these studies show also that the majority of cases which they looked at, only in a minority of those cases there was COVID-19 virus in sperm found. There are no studies looking at whether it's present in oocytes. I think in general, what everybody believes nowadays is, but really we don't know that for sure, that probably due to the processing of our oocytes and sperm in ART laboratories, you might dilute at least the virus, or probably get really completely rid of it just by the procedures which you follow to inseminate your oocytes or inject your oocytes. Similarly as it does with HIV patients and hepatitis patients. So I think the risk is really very, very low, but I have to admit, as others did in this series, that we really don't know it for sure. It really doesn't look like it is a big risk at the moment. And along with what our government says, that it doesn't, let's say, proclaim that people shouldn't try to get pregnant in these days because they don't. I think that it's very legitimate to reinitiate treatment again, because people are waiting for their treatments also, and they don't like to be, let's say, hindered in that attempt to become pregnant.
Based on everything that's been going on these last few months and what the situation that we're currently in, what's your outlook then on the future for reproductive care?
Well, I think that obstetrics in general and ART especially is not going to be much affected by COVID, as long as it's not, let's say, introducing things like that ART might increase the risk for infection for the offspring. As long as that's not the case, the trade we are in actually is not in whatever way interfering with, let's say, good COVID care. What we are doing in the Netherlands, and probably you are going to do that too in the US, we are now very much aiming at having COVID hospitals ready as soon as the second wave will hit us, in order to bend the curve again properly and to stay below the maximum load of ICU patients which we can handle. As long as we do that, and as long as we take care that enough people which are sufficiently trained are working in these COVID hospitals, there will be only a limited number of people from our world, from OBGYN and ART, which will be involved in there. First of all, because most of the time they lack a proper background training to do all this ICU work. The second thing is obstetrics goes on. So that's also kind of acute kind of medicine thing. So what happened in my hospital at least, there were only a few people asked from my staff to work in COVID clinics, in COVID units, because they knew, of course, that our staff was also very busy with the daily stuff they anyway do, because that's delivering babies and also making babies in a way. So basically, I think that we are not a trade which is, when we are fully operational again, we are not posing a certain threat on how we could run these COVID clinics in the future, because we are not going to be part of that very much, because we are dealing with our own stuff. And so that's an advantage of being in OBG, being a gynecologist and working as a reproductive endocrinologist and infertility specialist. On the other hand, yeah, I still fail to see that we are making large steps in getting these COVID units ready for a next wave, because that's of course important that we should do that, because in that way we could also go on with normal care, because that's really an issue in the Netherlands at the moment, that all kind of oncological care has not been given to people, with all kind of negative consequences, of course, of that. The other thing is our economy is collapsing. So if we don't have these hospitals soon enough in place, we are again not prepared for the next wave of COVID, which will definitely be there somewhere. It's predicted here, at least on this side of the ocean, to come somewhere in October, November.
Dr. Laven, thank you for sharing your insight and experiences with us today. We greatly appreciate your time.
Thank you.
This concludes this episode of ASRM Today. For show notes, other information, and discussions, go to asrmtoday.org.